Welcome everybody. I see that there are some people who are tigers for punishment and were here a few weeks ago during the storm as we listened to Professor Ralph Martins. Thank you again for your interest in the ongoing conversation about dementia that we at Alzheimer's Australia here in WA are keen to sponsor and support and generate in whatever way we can. And of course this public lecture series is very central to that conversation. I'd like to welcome you all, and as I start tonight I'd like to acknowledge the traditional owners of the land on which we meet and pay our respects, my respects to their elders past and present, and in fact pay my respect to all elders who are present in this room. Let's get on with the business of what we're here for tonight, and to welcome from overseas, although he has come via the eastern states and spent some time with the other Alzheimer's organisations in other states and territories, and is off at the crack of dawn tomorrow to sunny Albany to spend some time with our team down at Albany and Hawthorn House before wrapping up his visit to Australia, and in dealing with some of the most critical conversations that we need to have about dementia, and that is those end-of-life care issues. And so, Julian, we welcome you here tonight. As you have all read, Julian is a consultant in old age psychiatry in Northumbria Healthcare the NHS Foundation Trust, and an honorary professor of philosophy of ageing at the Institute for Ageing and Health at Newcastle University. He has studied philosophy as an undergraduate at Oxford and later gained a PhD in philosophy in connection to dementia at Warwick University. He qualified in medicine from Bristol University. He originally trained in general practice and then switched to psychiatry. He was appointed a Fellow of the Royal College of Psychiatrists in 2011. His writings and research focus on philosophical and ethical issues raised in connection with ageing and dementia, and he has had a particular interest in palliative care and dementia. And as I said before, of all of the conversations that we need to have about dementia, from an ethical point of view, from a care point of view, about supporting the family pathway, it's around those issues around palliative care and end of life. So Julian, we're really delighted to have you as part of our lecture series for this year, and we welcome having someone of your reputation and knowledge here among us. Julian will speak till about 7:20, and then, as usual, we will open the floor for questions and conversation about the issues that have been raised tonight. So would you all join with me and give Julian Hughes, Professor Julian Hughes, a great Western Australian welcome. Thank you.
Well, thank you very much, Rhonda. So I need to make sure I can still work this. Oh. That's very clever. So my first thing is just actually to thank you all very much for coming, and but also importantly to thank Alzheimer's Australia for organising this tour. It's just absolutely lovely for me to be brought here and looked after to do this, and but then also to thank Rhonda and Alison and Jason and Pam, who are from and the rest of the team here in Perth, who have helped put on this event for all of us. I have to say, and I don't say this, I don't say this lightly, or I'm not making it up, but it's actually a great privilege to come and speak, because I then meet lots of people. I've met so many interesting people. I hear lots of stories which are sometimes difficult, sometimes, terrible, but wonderful people engaged sometimes in difficult circumstances. So that's a great privilege, and so I'm grateful to you for your interest in this whole field. it's always good to start with a sort of joke, isn't it? Or some people say it's bad to start with a joke, but anyway. And so I've been trying to hone my jokes. I don't know that they're getting any better, actually. I think they're probably getting worse. But I have been pointing out to people that there is this thing in research. I know there are probably some people involved in research in the room, that association doesn't imply causation. So the fact that A and B happen together doesn't necessarily mean that A has caused B or that B has caused A. So it's always good to get that little thing sorted out. So I was last here in 2010, which was when the last Prime Minister was booted out, and then I've come back, and so I sort of witnessed that, and then I've come back and the reverse has happened. So it doesn't necessarily mean that there's causality, but if you want a change of government, invite me back. I'm always happy to come back. So, on with the show. So there's been a poster produced which has a list of questions on it, and I think the questions were set for me. I don't think I posed them to myself, but I just put that up just to remind me what the plan of this is, and the plan is to answer those questions, and in doing that, I'll also talk a little bit about advanced care planning, and I'll introduce this notion of values-based practice a bit later on, and end up saying a little bit about care pathways. Now, in the handouts, the thing that I wrote, which you will have been given, there's a bit more about some of this. So it's not as if I'm going to cover everything in what I say. Some of it will be in that handout. So the first question is, what makes dementia care at the end of life different from other chronic diseases? And my initial response to this is to say, well, actually, it's arguable whether it is different from other chronic diseases. And so I'm going to suggest ways in which it may be different, but that could be an argument. We could discuss whether or not it's different. And what I'm not going to do is give you the standard answer. The standard answer is to show you a graph of something like cancer or a graph of some other condition like, say, heart failure, and then a graph of dementia. And I'm going to say that the graph of dementia sort of dribbles on in a more unpredictable way, whereas these other things have a more predictable sort of trajectory. Well, people who specialize in these other fields now say actually all of these things are starting to look a little bit similar. So just as with cancer, it's not the case now that you get cancer and then you die. You often live with your cancer for years, and sometimes you don't even die from your cancer, you die from something else. So arguably, many of these conditions look a little bit the same. But there are some things that are different about dementia, and the first thing is that it's the mental disease of aging, which does mean that it attracts stigma, but there are sort of three things that constitute the stigma. There's just the fact of it being dementia, and dementia itself is a stigmatizing condition. There's the fact that you're aging usually when you get dementia. It's certainly associated with aging, and aging itself attracts a stigma. And then there's the fact that it's a mental or psychiatric disease in some sort of way, and that also attracts a stigma. So that led people like Tom Kitchwood, and those of you who are familiar with this field will know of the name of Tom Kitchwood. He was the man who invented the idea of person-centered dementia care. And he came up with this nice expression of malignant social psychology. And then Steve Sabat, who's a social psychologist from Georgetown in Washington, he sort of borrowed the phrase and talked about malignant positioning. So those two phrases, what they're about is the fact that although in dementia you have pathology in the brain which makes you ill, you can also be made worse by the pathology that might be out there, even from people who love and care for you. If they treat you in the wrong way, it can undermine your standing as a person. It can make you behave in ways which then look as though you're getting aggressive for no good reason, and then people will say, oh, it's the dementia making them aggressive, but maybe the person's getting aggressive for perfectly rational reasons, that nobody's letting them get outside and they want to go and do a bit of exercise or something. So what this suggests to me is that there's one way in which maybe dementia is slightly different, is that there's such a big psychosocial element to dementia, which we need to recognize. And the Nuffield Council on Bioethics produced a report a couple of years ago, which was the thing I came to talk about in 2010, and in Australia. And one of the things that's emphasised in that report is that it is possible to live well with dementia. Of course, dementia is a terrible condition, but if you get the psychosocial environment right, then it may be easier for the person to live well and to do well. So that might be something just to keep in mind. And the final thing is that despite that, there are physical things to do with dementia, but actually some of them are unrecognised. So people don't recognise, by and large, the palliative care needs of people with dementia. So that's one of the themes, really, is to encourage us to think about the palliative care needs of people with dementia. So I think these are ways in which it's slightly different from some other conditions. I've put up there the thing about the European Association for Palliative Care. That's really just to remind me to tell people who might be interested in this that fairly soon, actually, there should be a paper published in Palliative Medicine for the European Association of Palliative Care, and where the main researcher, who's called Jenny van der Steen, who we'll talk about her a bit later on, but she's gathered a group of people, and they've come up with a consensus statement about what would constitute good quality palliative care for people with dementia. This involved over sort of 64 experts in about 23 countries, including Australia, and so it'll be interesting for people to see that, I think. One of the first things that it says in that consensus document is that we should think of dementia as a terminal condition. So, on the next slide, I just want to consider what's good and what's bad about that. Well, what's good is that it's just straightforwardly honest, it's straightforwardly realistic. Actually, you know, this isn't, I mean, none of us wants to be told that we're dying, but actually we're all dying, sort of, aren't we? We can already say at this moment that most of the people in this room are going to die from cancer, heart disease, or stroke. You know, that's just what's going to happen to most of us here. And if you, I mean, it might be that you get dementia and you die from one of those things. But if you don't die from one of those things and you have dementia, then eventually you'll probably die from something connected with your dementia. So it's just straightforward and being honest about this. And the reason for being honest is because that might affect the sort of care that we get. It might make the care that we get more realistic and rational in some ways. It might help with resources. What's bad about it? Well, the obvious thing is nobody wants to be told that they've got a terminal condition. I mean, you might want to be told that you've got a terminal condition when it's clear that it really is terminal. But certainly nowadays, as you know, there's the big push to get early diagnosis. And if you've got very mild dementia, or even if you've just got mild cognitive impairment, a sort of pre-dementia type of condition, you don't want somebody saying, "Oh, sorry, it's also terminal." You know, it's just a bit much for people to be talking about that. So that might be what's bad about it. I've put up research just because in the UK at the moment there's actually a bit more funding for dementia research than there is for palliative care research. So if people think it's a terminal condition, they may think, well, we don't need to spend lots of money on it. Well, let's just, the next few slides then really just sort of help to make the point, you know, why are we talking about it as a terminal condition? So here's a study from Susan Mitchell in America where they looked at over 300 people in nursing homes with dementia, with advanced dementia, and they showed that 55% of those people were dying within about 18 months. And they also showed that a good number of those people had distressing symptoms. And actually, although this is a very good study and it's, you know, focused on nursing homes, similar studies have been done in other countries looking at slightly different populations. We've known this for some time, that dementia, especially towards the end stages, looks like the end stages of lots of other conditions such as cancer, in that people have distressing symptoms, but the difference in dementia is that they often get burdensome interventions. So they have distressing symptoms, but people are still then doing things which wouldn't be done with good quality palliative care. And just a few more details from that study by Susan Mitchell, just showing that in advanced dementia, you're likely to get things like swallowing problems, fevers and pneumonia and so forth. And if you get those things, then your chances of dying increase. So this really does look like it is sensible to talk about it as a terminal condition. Here's a study then from the UK by someone called Liz Sampson, who works in London, and what she and her colleagues did was that they just went to one hospital, they looked at all the admissions to that hospital over a period of time of people over the age of 70. They found that out of those sort of 617 people, they found that there were 75 of them died during that admission. And the point of the study really was to say that if you had a diagnosis of dementia, and especially if you were in the moderate to severe stages, your chances of dying went up 3 to 5-fold. So you were more likely to die if you had dementia. And so that's what that says, that it goes up 3 times or 5 times as much as if you didn't have dementia. And there's lots of good data in that study if people are interested in looking at it. But actually the reason I've put it up is partly because I like these couple of sentences right at the end in the discussion, where they say, we cannot judge from our data whether these admissions were necessary, but the high short-term mortality risk in people with dementia suggests that this intervention did not prolong life for a meaningful length of time. Individuals may have received better quality care in a familiar environment if more support were available in the community. So in other words, they're saying, what was the point of taking these people into hospital where they only lived a couple of weeks, and probably they had all the things done to them that would have been done to anybody who gets taken into hospital. They would have had needles stuck into them, tubes stuck into them, all sorts of investigations. It would have been confusing for them. It would have been frightening for them. Would it not have been better if they'd just been kept where they were and given good quality care, which doesn't mean no care. It still means analgesia and so forth. But for those people, for many of those people who died, the admission to hospital achieved nothing and quite likely made some things worse. So this is an argument in favour of a palliative care approach for people with dementia. The second question then is, what constitutes palliative care in people with dementia? And in a way, I'm not going to read through all of that. That's simply a World Health Organization definition of palliative care, and I've just split it up into different points. But it seems to me it's quite clear that it absolutely maps onto what we would want as good quality dementia care. Of course we'd want people to look after people's symptoms. Of course we'd want people to think about the carers. Of course we'd want to have some sort of holistic care that thought about psychological and social things, and so on. Of course we want all those good quality palliative care things. We can make the point slightly differently by looking at an older definition from the World Health Organization of palliative care, and then comparing that to the work of that man Tom Kitwood, who came up with person-centered care. And Tom Kitwood, identified what he called 5 psychological needs of people with dementia, which were attachment, comfort, identity, occupation, and inclusion. So I'm not going to go through them all to show how they sort of map together, but if you just think of occupation, I mean, people with dementia need meaningful occupation. They need to be able to feel that they're doing things, that they're engaged in some way, even if it's at a fairly simple level. And that, in a way, is affirming the person. It's affirming the person's standing, that they're still worthwhile, it's still worthwhile doing things with them. What then would this palliative care look like? Well, there are all sorts of examples all over the world, including in Australia. But here's just an example from America, where Joe Shager and Greg Sachs set up a sort of palliative care intervention in a fairly deprived part of Chicago. And they were able, and what this really just shows is that there was work to be done. There were things they could do, and they were able to get on and do it. It wasn't desperately high tech. They just had a nurse going in, giving people advice and so forth, picking up symptoms, talking to the doctors about what can we do about this or that. And they were able to show that you could have rational conversations about medication, and you could adjust people's medications, stop the unnecessary medications. They showed that some people, quite a few people, had pain of some sort, which you could do something about. You could control symptoms, you could give support to carers. And note that this was mostly an African American population who wouldn't normally have known how to get into the hospice route, and yet with just a little bit of support, some of them could do that, and then they got the benefit of enrolling in hospices. A similar thing has happened in the UK with a chap called Victor Parche, who is a palliative physician at St Christopher's Hospice in London. And again, he worked with a specialist palliative care nurse. The nurse, and I know that similar things are happening here in Australia, that the nurse then used to go into homes, had a series of homes that she had contact with. The homes could ring her up for advice and so on. And again, there were things to be done. There were symptoms to be controlled. There was psychosocial support to be given to people with dementia and to their family carers. There was also some expertise sometimes required in those things really at the sort of terminal stage of life, when it's the palliative care people who know things about syringe drivers and the exact doses of morphine and that sort of thing that might need to be done. So there was that sort of work to do. The most common symptoms they found, which were also the most severe symptoms, were weight loss, anorexia, weakness, and fatigue. So again, a little bit like many other terminal conditions, you get things like that. And there are also some more complex symptoms, such as severe myoclonic jerking, catatonia, and pronounced Parkinsonian symptoms. And then they did find that pain was quite common, but they made the point that pain was often mild. And I think that's an important point to make, that we're not saying that everybody with dementia is in pain and they all should be on morphine or something. Some of them might not need any medication at all. They might just need slightly different handling. But we'll come on to pain a bit later on. Of course, there were some people who needed to go into hospital, and they helped to manage that, and they also helped to get some people into hospices. And they concluded it's possible to identify patients with dementia who need palliative care input. So this is all just making the case that palliative care is a good idea for people with dementia. But then there's the idea of supportive care. So the question is, what does supportive care add to palliative care for people with dementia? And I want to say, in brief, to summarise what I want to say it's a broader model. So I'll just talk a little bit about the sense in which it's a broader model. Well, we could start with a sort of biomedical model, which really would focus on symptoms, and then that can be expanded to the biopsychosocial model, and then the palliative care model brings in the biopsychosocial and spiritual model. It brings in that notion of holism, so the whole person, but also the person situated in their family and so forth. So what does the supportive care model add? And I've said there it adds time and depth. And what I think it really does is it takes a sort of practical approach, and it says, if there's something that can be done now, we should do it. There are no holds barred. We're sort of not interested in faffing around. If there's something needs doing, we should do it. So it adds time in the sense that it's easier to think about supportive care even for that person with mild cognitive impairment who may or may not go on to get dementia. It's easier to talk about supportive care for that person. Of course, it goes all the way through to grief and bereavement, but also some sort of depth to it. So if the person needs vitamin B12, then give them vitamin B12. One of the things I said, didn't I, earlier, that I've learnt things by coming here and doing these tours. And one of the things I've learnt is something about men's sheds, which I'd never heard about a men's shed. And the person who told me all about this said that apparently we have them in England, so I'm going to go straight back and find the local men's shed. But I witnessed this person they'd been telling me about this, and then he was standing there talking from the Alzheimer's Australia, and so he was talking to me about men's sheds, and then the wife of somebody came up to talk to him, and just right in front of me described how the fantastic change in her husband since he started going to the men's shed. She didn't use the slightly sort of negative word of vegetating, but she was sort of describing him as sort of just vegetating. He was just sitting on the sofa. He wasn't interested. He looked depressed. He was sort of morose. He was getting irritable. There was no quality of life. He then started going to the men's shed twice a week, and now he is bright, he's happier, he's more like his normal self, and so on. If we can do it, whether it's vitamin B12, whether it's the men's shed, let's do it. And that reminds me that there's somebody in the audience who's a dentist. I think he's called Craig, but I've gone and forgotten that person's name, and I hope that they'll come and speak to me afterwards. Oh, is it you? Are you called Craig? Clive. Clive, it's nice to meet you. And so Clive, I think, in a very timely fashion, is emphasising to people that we need to think about dental care for people in nursing homes. And I've had a little email exchange with Clive where I've pointed out that there's, funnily enough, there was a dentist back in Newcastle upon Tyne who got in touch with us 6 months ago and said exactly the same thing. And it suddenly seems completely obvious that, of course, we should all be thinking about people's teeth. Actually, in the home where I work, where I look after people with who have sort of behaviour that's more challenging, and dental issues suddenly seem to have cropped up several times. We've had several people going to dentists and dentists coming in to see them. So if you need good dental care, then give good dental care. Let's give whatever it takes, whatever is going to make the person better. Let's do it. So I've said it's a broader model. There's less emphasis on death, and it gets rid of these sort of dichotomies between care versus cure, high-tech versus low-tech, biological, social, patient-centred, person-centred, being with, doing to. It gets rid of those dichotomies. I could linger over that for a while to sort of explain what each of those means, but I better not, because I'll ruin my timing. But just to look at the first one, because you might think, well, what's he talking about cure for? In a condition where there isn't cure. Well, remember that there are over 100 or whatever causes of dementia, and some of them, potentially, it makes more sense to talk about cure. Think of normal pressure hydrocephalus, which is where you get fluid building up in the brain, and a simple shunt put in to drain the fluid down to some other part of the body can affect a cure. In my experience, I've never seen anybody completely cured, but I've seen them made much, much better once that's been done. But think of HIV/AIDS, where if you don't have proper treatment for your HIV/AIDS, you'll probably, if you don't die from an infection, you'll probably go on and end up with HIV/AIDS dementia. But if you get proper treatment, you don't get the dementia these days. So another thing, it's sort of preventative, but it's sort of thinking in a curative way. And I suppose what I want to say is we need to have curative intent. So curative intent is the same point. If there's something that can be done, let's do it. That's what I think the supportive care model tells us. So it's a model with depth, and it asks the question, what needs to be done now? And then it suggests that we should just get on and do it. And if we did that, then we might end up with some sort of hypothetical graph like this. It's totally hypothetical in that you'd have to have a way of measuring the ethical input, the legal input, the spiritual input, and so on. And I don't quite know how you'd measure those things. But I like this graph for two reasons. One is that you can ask the question, what would the perfect graph look like? At each point in dementia, from diagnosis to grief and bereavement, how much physical care would you have? How much psychological care? How much spiritual care would you have in the perfect graph? And you can also use this graph to ask the other embarrassing question, which is, if you think about somebody, a real person with dementia now, what would their graph look like? How much spiritual care would they have had? How much social care would they have had? How much psychological care? And so on. Well, that use of those models, in a way, what it shows is a sort of broadening, and I'm sort of suggesting that as the model broadens, that's a good thing. So it broadens from the biomedical, biopsychosocial, spiritual, and so forth, and supportive is broader still. It then raises a slight sort of philosophical question, which is, what if it broadens out further? So if it's a good thing to keep on broadening out, what do we get to? Well, I think what we get to is just real life. We get to the world without models. And one of the things I've said is that the world without models is a world of real human encounters, where embodied subjects meet in the raw. But the world without models is also a world without science. So just to think about that very briefly, it's making the point that when we meet, however we meet, under whatever circumstances we just meet as human beings, as flesh and blood. We just have conversations together, we talk with each other, we engage with each other. We don't do that through models. So this isn't, however, an anti-science point. It's just placing science into the right sort of context. So having met you and having had just the meeting in the raw, as it were, we might then decide that if I'm going to help you, I've got to use a certain model to think about how I'm going to do that. And then, of course, I need the model and I need to think in a scientific way. But that's in the context of just me meeting you as a human being. And that's what people with dementia need, no less than the rest of us. And we know that when we're met and we're treated as if we're a thing, and somebody's just thinking about us in terms of some sort of model, it's uncomfortable and we don't like it. Okay, so the next question was, when should discussions take place about end of life for people with dementia? And the easy answer is just to say that they should take place in a timely fashion. And so there has been something in your news recently about making a diagnosis in a timely fashion. And of course it leads to the question, what is a timely fashion? And the answer is that there's no absolute answer to that. It's not for me to say, oh, this is when you should do it, or this is when you shouldn't do it. There may be times when it's more obvious to think about it. It may be a bit more obvious to think about it, for instance, around the time of diagnosis. Maybe then that might be the time at some point with some person to think about it. Maybe if you're going into an aged care facility, maybe that's the time to start thinking about it. Maybe at just an annual health check when you're 75 years old, or whatever it is. It might be a time to raise the discussion. Whoever raises it, though, whichever professional engages in that discussion with you, they need to be focusing on exhibiting the professional virtues. They need to be doing no harm, doing some good in terms of those conversations. That's what beneficence and non-maleficence mean. We could stick up there the word autonomy, in that they should also be directed to some extent by your wishes. They're going to have to use their practical wisdom, their sort of understanding of these things built up over the years of experience in order to judge when it's best to have that conversation. Certainly they should have it with honesty and fidelity, the notion of fidelity being sort of true to you. And honesty partly means that when we're moving towards the conversation, we should have the conversation. You know, we don't then back away from it and hide it. But however we do it, we should do it with compassion and care. The idea of having these conversations, of course, then raises the issue about advanced care planning. So the next few slides are just going to be for me to make a couple of points about that. And I'm going to use this study by Louise Robinson, who's one of my colleagues in Newcastle upon Tyne. And so she did a study over a couple of years. And of course, all these studies always start with a systematic review of the literature to look at the effectiveness. Does advanced care planning actually work? And what we found when we did that was that there were only 4 studies which were of any good quality. There are always, 1,000 studies have been done, but only 4 of them are any good. And 2 of them were from America, 1 from Canada, 1 from Dr. Kaplan in Sydney in Australia. And they did indeed show that there was some evidence that advanced care planning can be effective. It can be effective in terms of reducing the number of hospital admissions and so on. What does it mean? It often just means a simple conversation. It was just nurses going into units talking to people and saying, have you had this conversation? Have you thought about it? As a family, have you thought about it? As nurses, have you thought about having the conversation? And so on. Well, in Louise's work, there was then went on and there were some focus groups and interviews with various professionals. And what that showed was that there was just complete uncertainty about this notion of advanced care planning. Now, I'm not going into this in depth. Advanced care planning means lots of different things, doesn't it? It means advanced refusals of specific treatments. It means the appointment of attorneys. It means writing down advanced statements and so on. And as here, there's quite a sort of central push for people to have advanced care plans. It's sort of government policy in the UK. And yet here are all the professionals, and they're all in a complete stew about it. They weren't convinced it was actually going to help people. They were worried that they would start to have conversations, and then somebody would say, okay, well, my advanced care plan is I want to stay living in this house, and then they would think to themselves, but what are we going to do if they start beating up their wife or something, or start wandering around the neighbourhood in the middle of the night? How are we going to keep them in their home? So what's the point of doing this if we can't actually keep them there and honour their wishes? And then everybody said it was somebody else's business. So the doctors said, oh, it's the nurse's business. Nurses are good at talking to people. Nurses said, oh, no, we don't understand this. It's the doctor's business. Doctors should do it. The palliative care doctors said, no, it definitely should be the old age psychiatrist should do it. They said, no, it's the palliative care people who should do it. And then everybody agreed it's the GPs who should do it. But the GPs said, no, we shouldn't do it. It's a sort of specialist thing. So, and then people got very worried about the sort of legal forms. And despite the fact that we have a fairly clear legal framework in the UK, people were uptight about what was legal and what wasn't and so on. So there's just a whole lot of sort of worry about advanced care planning. And I wonder if that's just because we've got it out of perspective. We have to ask, what's it really trying to achieve? How are we really going to show that it's been effective? It may be that it actually, of course we can tick the boxes to say whether or not people have been admitted to hospital, but maybe actually it's really just, again, about human engagement. Maybe actually, in essence, advanced care planning is again about a conversation. Now, I quickly want to say that people have been critical of this idea, and they say, but listen, you've got to get the right forms filled in. It's very important that the forms help to guide the conversation and so on. My response to that is to say, yes, the forms are important. You are, in some cases, you are moving towards some sort of legal decision about things, and therefore you have to have it done in the right way. But let's understand what it is. It's a conversation with people about their wishes. It's not a complex legal thing in that sense. It's simply trying to record the conversation in a way that will be helpful legally later on. Okay, the fifth question was, how should pain and distress be managed? And I'm not going to say everything that could be said about this. I just want to look at this paper by Alice Jordan, who again was a palliative care physician, and you'll note that the second person on that paper was Claude Regnard, another palliative care physician. And what happened in that study was that Alice went round about 4 nursing homes for people with severe dementia, and she used 2 instruments. One of them was called PainAD, and this is where you just observe the person and you look at their breathing, their negative vocalizations, facial expression, body language, and whether or not they can be consoled. And then you can give them a score out of 10 to decide whether or not they're in pain. And if they score 2 or above, then they're probably in pain. This is not too dissimilar from the Abbey scale developed by Jenny Abbey in Australia. So we use that as a pain scale, and we also use something which Claude Regnard, one of those authors, developed, which is something called Distat, which he says is a distress tool. And there are then really 2 things to say about this distress tool. The first thing is the reason Claude calls it a distress tool is because he wants to make the point that what comes first of all is distress. You need to pick out distress. And once you've done that, you can ask the second question, which is what's causing the distress? And he says in some cases it will be pain, but of course it may be other things. It may be things like hallucinations or whatever. Then what you do is, the second point about this is then you fill in the form, and this particular one is guiding you towards looking at facial expression, but actually each form has to be filled in individually for the individual person. And the way you fill in the form is by talking to the carer who knows the person best, either the family carer or the professional carer, and you just say to them, how would you know that Joe is distressed? How would you know that Joe is content? And then you list the things that would show you that Joe's distressed and the things that would show that Joe's content. It's predicated on the idea, on the thought that actually people who know the person will know these things. They'll know when Joe is upset and so on. So you then end up with an individual form for Joe. And just to make the point of how individual these things are, there was somebody in this study where we knew that they were distressed when this lady rolled her trouser leg up. So it was the trouser leg sign, and it was unique to her. And it was because she sort of would start to fiddle with her fingers on her leg, and then her trouser leg would slowly sort of roll up as she fiddled. But people sort of knew that. They knew when she was upset that's what happened. Well, you won't find the trouser leg sign on any other pain tool anywhere. What this shows when you do this is that there are loads of symptoms of distress, and I know it'll be difficult to read some of those, but all sorts of things are signs of distress. So one of the points of this study is that you need to be quite careful in using these tools, that you're not just jumping to conclusions about pain. One of the things that upset one man, for instance, was that he was sitting the observations were going on, he was sitting at the dinner table, and the next man stole his chips. and he started to shout and grimace and so on, and soon he was scoring 5 or 6 on the pain ad, and everybody was rushing off to get him some morphine. They just needed to give him some more chips. And so we just need to keep that in mind. Alice, who was trained in palliative care and geriatric medicine, she did a very thorough job at picking out those people who really were in pain. And I suppose the serious point is that can sometimes be difficult, understanding that it definitely is pain and what sort of treatment to give. So Alice was very sure that she had a group of people who definitely were in pain. That was on the basis of her observations, examinations, looking in the notes, talking to the GPs, talking to the carers and so on. There was another group who we were sure weren't in pain, but they were distressed by something else, like somebody stealing their chips. And then the thing to notice is that these things just crisscross. There isn't one thing that you can say, this shows that this person is in pain. There just isn't one thing. The final question is, how are ethical issues to be dealt with at the end of life? And so when the Alzheimer's Australia very kindly brought me out here a couple of years ago, in 2010, I talked about this. So I'm not going to enter into a huge thing about it again now. I would still commend that report from the Nuffield Council on Bioethics, which is freely available from their website, and there's also a summary statement of it. But I just thought I would just skim over the framework that they suggested at the very start of that report, before they got on to the sort of particular details. So just a quick look at that framework. Well, first of all, it says that if there's an ethical dilemma, you don't then start with some great principle from Aristotle or Kant or whatever. What you do is you look at the particularities of the case. You look at the facts involved in this particular case and try to get those clear before you do anything else. You have to recognize that dementia is a harmful brain condition, but at the same time you have to recognize that we can do things about it just by altering the psychosocial environment, and it's possible to live well with dementia if we get that right. The central nub of it all really was probably to do with promoting interests, but then the report made the point that, so we're trying to promote the person's interest in autonomy, promote their interest in well-being and so on. But then the report made the point that none of us is fully autonomous. The better notion is really the notion of relational autonomy. So I might think I'm autonomous standing here, I can decide what I do next and so on, but actually I'm completely not autonomous. I don't know the way back to my hotel. I can scarcely remember the name of my hotel, so I'm totally dependent on other people. So the notion of relational autonomy means that you also need to take into account the interests of the family carers and so on. And then this important notion of well-being and the thought that actually for people with dementia, well-being will often be moment-to-moment well-being. So part of my well-being now is that I can remember what happened yesterday and I know what we're planning to do tomorrow and so on. For somebody with dementia, that may not be possible. And yet, just somebody pausing just to talk to them for a couple of minutes, say hello to them, call them by their name, ask them how they're doing, comment on the weather or whatever it is, that might just boost the person a little bit. And if it happens 5 or 6 times a day, then they're boosted a little bit 5 or 6 times a day. And at the end of the day, they would feel better than if they hadn't been boosted at all at any point in the day. So moment-to-moment well-being is important. And then finally, and we could talk about this for hours, but the notion of solidarity, the idea that we're all in this together. If it's not affecting me and my family, it'll be affecting the next door neighbour and their family. This is a societal issue and one which we have to do something about. And then also finally this idea of personhood, that it's important to remember the person with dementia, as Tom Kitt would have said. Don't just remember the dementia, remember the person, and we need to still remember that there is still a person there and that we should value them. So that was that framework, but still just thinking about ethical issues. These are the sort of normal ethical issues that get sort of raised at the end of life, and I'm going to touch on them very briefly, but not say much about them. In line with that Nuffield Council, that framework, the first thing was to get the facts right. So if we're going to think about any of these issues, we should try and get the facts right. So I just want to present a couple of slides showing you the empirical data for one or two of these issues. So Liz Sampson, whose work I mentioned before, with colleagues, they've done a review of the literature looking at artificial feeding for people with severe dementia. And as with previous studies, she's shown that there's no good evidence that artificial feeding with tubes up the nose, tubes through the abdominal wall, peg tubes into the stomach, there's no good evidence that this is helpful for people with severe dementia. You may decide to do it in particular cases for some particular reason, but overall there's no good evidence that it's helpful. The things you think it might do, you might think if you do this, then the person won't get aspiration pneumonia. They won't have food going down the wrong way because it's going straight into the stomach. But actually people still get pneumonias even if they've got peg tubes in, because you've still got mucky secretions going down the wrong way. You might think if you do this people won't lose weight because you can pour in the right number of calories and so on. But actually in severe dementia, people lose weight even if you're pouring in the right number of calories. So although the bottom point there just makes the point that weight is an important issue in dementia, but maybe it's an issue we should be attending to sooner rather than leaving it to the end and then saying, oh, do we need to start putting in feeding tubes? It's important because if people don't have weight, then they're more likely to get pain and so on because of loss of body fat. Here's some more empirical evidence. If you're interested in antibiotics, fevers and so on, just look up the work of Jenny van der Steen. There are loads of studies that she's done. And I just like one of the studies that she's done where she shows that, again, we need good clinical judgments about these things. She's shown in a group of doctors in the Netherlands that in using antibiotics, they're making quite nuanced judgments. For some of them, they're thinking, okay, we're going to use antibiotics because we're absolutely sure that this infection isn't going to kill the person, it's just going to make them ill for 10 days. We're going to use the antibiotics and then they'll be better by tomorrow or the next day. So they're using it curatively. There's then a big group of people where actually they don't think it's going to cure the person, but they think it might be useful as a palliative measure, because I'm told that antibiotics can decrease the stickiness of some of the secretions and so on and make the breathing a little bit easier. So maybe you just give the antibiotics for that reason. And then finally there'll be a group of people where it's clear that the infection is sort of overwhelming and really the antibiotics aren't going to be useful unless you want to drag the person off to intensive care and start to artificially ventilate them and so on. And so doctors are making the decision, well, we won't give antibiotics to that group of people. So we need to think carefully about, it's not just that you can say we should use them or we shouldn't use them. There are these sort of gradations, which is what Jenny has managed to show. Well, some of those issues are about withholding or withdrawing treatments, and I just very briefly want to introduce, if you haven't come across it, this doctrine of ordinary and extraordinary means, because I find this is practically useful as a thing you can actually talk to people about. You don't necessarily use all these words, but what this doctrine says is that we're morally obliged to do the ordinary things. So the ordinary things are just keeping somebody clean or whatever. There's moral obligation to do that. But we're not morally obliged to do the extraordinary things. We might choose to do the extraordinary things under extraordinary circumstances, but we're not morally obliged to do the extraordinary. What determines if something's extraordinary or ordinary? Well, it's extraordinary if it's unlikely to work, unlikely to cause harm. So the perfect example of this is resuscitation of somebody with severe dementia. The evidence is that it's about as unlikely to work as it would be if you tried to resuscitate somebody with severe cancer, metastatic cancer, which has spread throughout the body. In those people, resuscitation is very unlikely to work, and people wouldn't normally think of it. And it's about the same sort of chances of success in severe dementia. Plus, in somebody who's in the severe stages of dementia who's very thin, you're quite likely to be breaking bones and things when you try to resuscitate them. So why would anybody think that there's a moral obligation to do something that isn't going to work and is probably going to harm people? And this doctrine says there isn't a moral obligation to do that. If there's some sort of extraordinary circumstances why you might want to do it, then you can consider it. But you certainly shouldn't feel that your family shouldn't feel morally obliged to say that this is what they want to happen. Well, we are getting very near the end. Okay, thank you. So still, this is a little bit random, but I just wanted to introduce this idea of values-based practice. And so it's been developed by this man, a chap called Bill Fulford, who's a psychiatrist in the UK. And if any of you want to read a really good chapter about it, there's a reference up there. But actually, you can just go to the Cambridge University Press site, and they're now developing a whole series of books on values-based practice in palliative care, values-based practice in neurology or whatever. There are really only 2 points to make about this. The first point is that we need to recognize values. Values-based practice is complementary to evidence-based practice. So all doctors these days practice evidence-based medicine. So they want to know, what are the facts? How do we know this is going to work? What's the evidence? Values-based practice says that's very important, but then what's going to determine what you do with the evidence will often be to do with the values. And we just need to get the values out into the open, out onto the table. So we might know something about the values of the person with dementia, but then there's the values of the professionals, and then there's the values of the devoted son, which suddenly it transpires those values conflict with the values of the devoted daughter. So if we're going to do this properly, we need to be talking about all of those things. So the second point about values-based practice is that it then emphasizes the importance of good communication skills. Because we've got to get those values onto the table, and then we've got to reach some sort of consensus. And if we can't reach consensus, and we're going to end up with dissensus, then at least we need to be clear about why we have given weight to this person's values and not that person's values. We need to at least be clear about that. That's really what values-based practice tells us. So I'm going to end, and I said that this would be the briefest bit, just talking about care pathways. And of course, you need someone to lead you on your care pathway. You need to have your sort of advanced plan about what you might want to do on your pathway, so that your recorded conversation, you're going to come across all those different components that we highlighted from supportive care. And then there are going to be all these sort of different values at play in thinking about this. And so here is some, and this is spelt out in the document that you'll have been given, that, and the chart in the document you've been given is much bigger than this, and it has lots of gaps in it, and it just makes the point that for each individual under those lines of psychological, social, spiritual, and so on, there'll be different things. Somebody will be very keen on aromatherapy, other people won't want aromatherapy. Some people will want to go to the men's hut, I've forgotten what it's called, shed, the men's shed, and some people won't want to go to the men's shed, and so on. So it's going to be different. I must get that right, mustn't I? And so in my hospital, when we talk about care pathways, what we normally presented with then is a big bundle of bits of paper. So people say, oh, here's the stroke care pathway, and it's just a big folder with loads of bits of paper in, with lots and lots of boxes to be ticked and little things to be squiggled on, and most of the pages remain totally blank, and everybody says that's the care pathway. The care pathway, of course, is actually the person setting out on a journey, and they're accompanied by their professionals and by their friends and family, and they're going into this unknown terrain where they're going to be different things from the biological, psychological, social, spiritual, ethical, legal, and so on. And they're going to have to negotiate and navigate their way through that terrain. So that's really what a care pathway is about. And we have to think about how we're going to do it. But if we do it right, then perhaps we'll get to the perfect one of these diagrams. So in conclusion, again, when I came last time, there was very early on, there was a sort of media interview, and the person interviewing me said, so I hear you've come to talk about a revolution. And I thought, gosh, have I come to talk about a revolution? It turned out that the media release from Alzheimer's Australia had said there was going to be a revolution. And but then afterwards I thought, actually, it's a rather good idea. We do need a revolution. And I know that Alzheimer's Australia have led a sort of camp. There was a meeting when you all marched on your parliament in Canberra. So we're heading towards a revolution. So I thought you might like this quote. So this could be Tom Kitwood talking about needs and a lot of challenging behaviour. When we talk about challenging behaviour, we often then say it's to do with unmet needs. So what if in my work I could say this? At the end of the day, I could say this to the people I've been looking after. In your enjoyment, I would have had the direct enjoyment of realizing that I had both satisfied a human need by my work and also objectified the human essence and therefore fashioned for another human being the object that met his need. So it's slightly odd language, but it could be Tom Kitwood, but actually it turns out it's Karl Marx. So we really do need a real revolution. We need the supportive care revolution, which I'm suggesting will involve a lot of palliative care. It will be holistic, person-centred. It will be top-down in that we actually do need the governments to do things for us. We do need the top scientists to tell us what the best thing to do is. But it should also be bottom-up in that we need people with dementia to be leading this and their carers and the professional carers at the coalface. Of course, it should be an integrated and whole system revolution, but at root, it also requires personal commitment. And it requires the personal commitment of people like you and me. Thank you very much. I suppose I've got several sorts of answers to it. I mean, the thing is that everybody's going to have, there are going to be different views about the rights and wrongs of assisted dying. And in a way, it's not that I want to steer clear of all of those arguments. I just think that takes us onto a different page in a way. I'm quite happy to go onto that page. I think ALZHEIME'S Australia, next time you want a new government, should invite me back to talk about euthanasia. I'm happy to do that. My views about it, there's no point in me being shy about it because I've written about it, and my views are that I'm steadfastly against it. Okay. Now, but in a way, I don't want to now sort of enter into all of the reasons why I'm against it. That would almost be unfair because some of you will have jolly good reasons why you're in favour of it. Actually, and I mean, this is probably not to the point, but I've just written an article for one of our college's journals with somebody who's very steadfastly in favour of it and very at the forefront of the debates in the UK in favour of it. And so we wrote this article where I would write a bit, send it to him, he would write his bit, send it back to me, and so on. So it's a real sort of debate. And it is sort of interesting that, you know, we're just sort of, as it were, highlighting different sorts of values. In a way, it's a bit like that values-based practice thing. If you value one thing, you go for euthanasia. If you value something else, you know, you're against it. But in a way, I don't want to get into that debate because I think that's, as I said, the best way I can think of putting it is that I think that is, you're right, it's relevant, but I think it's a different page. But my real response to you at the moment is to say, let's get all these other things right before we start thinking that the solution is just to start killing people or letting people kill themselves. Let's get these other things sorted out. I mean, what about moment-to-moment well-being? Let's see what we can do about that first before we start deciding. I mean, actually, you know, one of the other many interesting things of doing all of this is that I have lots of conversations with taxi drivers. And many of the taxi drivers have said things like that, and you know, I don't then start to have a fisticuffs with them or anything, but often their preface to interestingly, their preface to this is an absolutely negative one about dementia. Well, the question then is that the reality that we have to be absolutely negative about dementia? If it is the reality, well, then maybe we should be moving in the direction of assisted dying. But actually, if just by changing the way people work in nursing and residential aged care facilities, if we can boost people's quality of life just by doing that, people say, oh, they have no quality of life. You wouldn't keep a dog alive with no quality of life like that? Well, let's try and improve their quality of life before we start taking them down to the people who kill the dogs. I would say sort of three things. I mean, first of all, we've reorganised our service just over a year ago, and I won't start boring you with all of that, but it's introduced me to a far greater extent to the benefits of having a really good challenging behaviour team with people who really know what they're doing and are good at doing it. And so that would just be the first point. Now, those people in the team that I work in, those nurses who are really so skilled, I mean, actually, they're not against the use of medication at all. And, you know, so I think we have to take this holistic view where we're going to attend to those psychosocial things. We're also still sometimes going to give antipsychotics and so on. Despite all the bad publicity, antipsychotics will sometimes be necessary. But we have to give them with thought and monitor and the smallest dose and stop them as soon as we can, and so on. So that would just be the first point. Second point is that one of the things that I've learned from palliative care people is that actually the notion of double effect doesn't actually seem to be that applicable to the use of morphine. Because what they tell me is that if you have pain, then morphine won't kill you. You can, so if somebody suddenly gave me a large shot of morphine now, it would kill me. If I was in agony and they titrated the dose up, they could get to very, very high doses and I'd still be perfectly all right. I just wouldn't have my pain. So it might be that morphine used appropriately actually doesn't cause this problem. It may be that it's caused by other drugs, actually. So that's just worth considering. As a sort of parenthesis at the end of that second point, one of the other privileges of this of doing this lecture tour has been that I've met Professor Ian Maddox a couple of times, who's the Senior Australian of the Year and a palliative care physician. And he was talking about his experience of sometimes using really tiny doses of morphine, actually just solely to get rid of distress without really knowing whether or not there was pain, but just thinking it might be a way of settling distress. So there are sort of clever things like that that we have to become a bit more savvy about. And then the third point, to get to your point about double effect, and I, I'm going to say this in a sort of in a brief way, which I'm not sure how clear it will be. But I think we need to sort of, because there's a way of putting the doctrine of double effect. I mean, that makes you just sound absolutely silly, actually. And the way, and it's the way that philosophers often put it. So most philosophers just think it's rubbish. If you read philosophy about double effect, they just think it's rubbish. And because they say, how could it possibly be the case that just because I have a little conversation in my head, that somehow changes the nature of what I'm doing? So just because I say, I wasn't intending to kill the patient, I thought it would be helpful. But everybody knows that this is going to kill the patient, and it can't just be that just because of what you say in your head about whether you were intending it or foreseeing it changes the moral nature of it. But I think that's to misunderstand the word intend. So the point about double effect is that it says that although you might be able to foresee that something will happen, if you didn't intend it, that's okay. Now, just note that actually, contrary to the philosophers, actually doctors are doing this all the time. I mean, I can often foresee that a tablet I give somebody might lead to some side effects, but of course I don't intend the side effects. So these two words are different words, is the first point to make. I can foresee that if I give somebody a high dose of aspirin, it might upset their stomach or whatever, but I'm not intending to upset their stomach, and so on. But I think the crucial issue, which is a difficult philosophical one, is that we tend to think of intention happening in the head, whereas I think you can talk about an intention being embodied in the action. So then what you have to look at is the nature of the action itself. So if I and actually this isn't, that might sound strange. This isn't strange. If in a court of law I said, well, when I pointed the gun at the person behind the bank teller and pulled the trigger, I wasn't intending to kill them, I just thought it would frighten them. And the judge is going to have no truck with that. And they're going to say, if you point a gun at somebody and pull the trigger, you're intending to kill them. The nature of the action is that it kills people. And so I think that's the question, really. What's the nature of this action? So in brief, if I'm giving small doses of morphine and I'm slowly, cautiously increasing the doses, then the nature of that action is called good medical practice. If I go running into some room with a massive syringe of potassium chloride and put it into them when we know that's just going to kill them, that's just called murder.
To the nursing home, so.
Well, some big issues there, really. I mean, one big issue is just to do with the very difficult emotions involved in being a daughter and going to see your mother. And as we know, people often say things to the family repeatedly that they don't say to other people. So they may spend the rest of the day seeming to be enjoying things, and then when the family turn up, they tell them it's terrible and they wish they were somewhere else and they want to go home. So that's a very, very common story, very difficult for families to deal with. But I think that you've probably answered your own question in that it sounds as though you're fairly sure that your mother is getting reasonable care in this home. And the difficulty is that if you moved her, you'd have no guarantee that it would be any better. Of course, it might be, but I think the number of cases where, unless a home is really terrible, which of course some of them are, but the number of times where moving somebody improves things is probably relatively few. It's probably that the question really is, what does she really want? And she probably really wants to be at home or to be with you or something, and that isn't going to change whatever home she's in. I mean, I'm certainly not saying that you should never change a person's home. I've seen cases where families have said, look, we're just not happy with this. We want my mum moved, the mum's moved, and things are better. So it can happen. But there are those other things to think about before. No, the honest answer is no, we're not. But I think that there are just pockets here and there where you can see things being developed. And the trouble is, I think, I was talking about, it's the policy that we're all meant to be doing it. The trouble is recognizing that it's an immensely complicated thing. It's immensely complicated at every stage. So the people who I think are best at doing it, in my experience, have been the palliative care people often. But they tell me that actually when they're doing one of these advanced care plans, which they've been doing for years with their patients with cancer, it takes hours and hours. It takes hours and hours to have the first conversation, then they have to go back and have another conversation and another one. Then they have to write the forms out and fill things in. Then they have to make sure the person's happy about it. So it's a tremendously labor-intensive business. So it's not a simple thing. Where you can see it starting to bite a little bit is where a whole area, somebody has had the motivation to get a whole area on board with doing it in the same way. So there is an initiative in London, which I heard about, where everyone is using a certain sort of computer system. And this includes not just the GPs and the emergency departments, but also the ambulance people and so on. So the moment an ambulance is called to a house, they can look up on their way and they can see, yes, there is an advanced care plan, and it changes what they're going to do. And they know, as they're driving to the house, they know we're not going to take this person in, unless it's such and such. So there's that sort of thing. In the northeast where I am, actually that man, Claude Regnard, who's one of the palliative care physicians, he's instituted a whole load of forms, got a whole load of people from everywhere. And the trouble is, it took a couple of years to do it, to get all the right people into the room at the same time, get them all to agree on the form. I was hardly involved, but I saw all the emails with, somebody from pediatric medicine saying, we don't like the word not in paragraph 2.3, and it just went back and forward like that. But eventually we have got everybody agreed on at least the same forms. It's not yet computerized, but the ambulance people, the GPs, the hospitals, the care homes, and then it's also now involved a GP and a couple of palliative care nurses going into the care homes specifically to say, look, these are the forms that we're all using. This is how you should fill them in. Have you started to fill them in? Do you want us to help you? So it's a massive effort. And so the answer to the question is still no, but at least in a couple of places here and there, things are moving. But it has to move in that sort of way. It's absolutely standard that Lewy body dementia shouldn't have neuroleptics, that they should be avoided specifically in that condition. I'll just quickly tell you that we're doing a little project. I've got a fantastic colleague who's called Dr. Wazim Bakir, who is Scottish, and he's a lovely chap, and his nickname is Waz, and Waz is going around the nursing homes doing just the title of the project is that he's optimizing medication, and mostly optimizing means stopping. Now, he is sometimes starting medication, he's sometimes increasing people's doses of things, but only in a few cases. Mostly he's just stopping unnecessary medications. And the feedback from the homes, and I can't remember the figures off the top of my head, but on average he's stopping sort of 3 or 4 medications per person. And the feedback from the homes is that the people are much better. they're less sedated, they're less likely to fall over, they look brighter, they're engaging more, and so on. And it's not just psychotropic medications, it's also just, all the other things that people are on. The things to lower cholesterol, the things to stop fall, the things to protect your bones, and so on. People are just on huge concoctions of things. I'm not, in a way I have to say, I'm not sure because I'm not well enough informed about the sort of agreements and contracts. But certainly, as you know, in the UK, if you're registered with a GP, if as a GP you were asked to see somebody and you didn't go to see them, you would be in big danger of getting in big trouble with the General Medical Council. You wouldn't get in trouble if the person didn't need to be seen, but if anything then happened to them and they hadn't been seen. So, the answer in the UK would be if a particular GP was just refusing to come in at all, ever, you'd send a letter to the General Medical Council, is what I would.